Good evening, everybody, and welcome to Transplant Talk Live, Arrow, the Bone Marrow Transplant Foundation's webinar series. These webinars are an opportunity for us to delve deeper into a number of BMT, stem cell, and CAR-T related topics, with tonight's webinar introducing you all to the wonderful organisation of Stem Cell Donors Australia. I'm Angela, I'm the Patient Liaison Officer with Arrow, and I'm joining you today from the traditional lands of the Wadawurrung people in the Geelong region of Victoria. I have with me today our wonderful host, Yvonne Panic-Hudson. She is a clinical nurse practitioner in haematology at both the Peter MacCallum Cancer Centre and the Royal Melbourne Hospital. She's also the co-host of the fabulous and very informative podcast, The Straight and Marrow. And Yvonne is also one of the directors on our Arrow board. And she is joining us today from the traditional lands of the Wurundjeri people in Melbourne. Along with Yvonne, we are very fortunate to have two wonderful guest speakers with us tonight. We have the CEO of Stem Cell Donors Australia, Lisa Smith, who is joining us from the traditional lands of the Gadigal people in Sydney. And we have the Medical Director of Stem Cell Donors Australia, Hung Yang, who is joining us tonight from the traditional lands of the Darug people. I'll shortly hand over to Yvonne, who will be facilitating our Q&A, which will hold on completion of both Lisa and Hung's presentations tonight. So please, if you do have any questions along the way, pop them in the Q&A section. You're also welcome to use the chat section. We will be monitoring this throughout the evening, and we'll endeavour to answer everybody's questions as best as we possibly can at the conclusion of our panellists' presentations. We will please ask you to keep in mind that we're unable to answer any questions regarding your own health status, that we can only provide general advice, and we kindly ask you to please contact your treating healthcare teams if you do have any questions that arise from tonight's webinar. So without further ado, please enjoy tonight's webinar, and I'll now hand you over to Yvonne.
Thanks, Ange, and thanks again to Arrow for hosting these wonderful webinars. They're so popular. You know, up until now, we've had a really clinical focus on our webinars, and it's really fantastic to have Hung and Lisa with us tonight to talk about what happens behind the scenes, to tell us about Stem Cell Donors Australia, previously known as the Australian Bone Marrow Donor Registry. So Lisa is the CEO of Stem Cell Donors Australia and has spent a decade as a senior executive in Australia's National eHealth Transition Authority and brings a wealth of experience in working with government and stakeholders to fund and deliver collaborative outcomes. Dr. Hung Yang is the Medical Director of Stem Cell Donors Australia and also works at the Australian Red Cross Lifeblood as a blood and marrow safety analyst. And he has a particular area of interest in the assessment and testing of voluntary blood and marrow donors. It's wonderful to have you both here with us, and I'm delighted to be hosting tonight's webinar. And I'd like to invite you to share your presentation.
Thank you, Yvonne. And just bring it up. Share, hopefully. Okay, let's see. Oh, one too far. All right. So look, thank you for that introduction. And yes, Stem Cell Donors Australia, just by way of starting, is a charity. We've been around for a little over 30 years now. And we interact with donor registries all around the world. There's around 80 odd all around the world. And we all basically do the same sorts of things. So what we're going to do today is take you through some of the key things that we do and our donors do in relation to making a donation for Australian patients, but also overseas patients in need of a stem cell transplant. So in Australia, unrelated donors are used in around half of stem cell transplants each year. And this chart here shows really the relationship, I guess, with the overall number of blood cancers diagnosed each year. Now, obviously, stem cell transplants are carried out for more than blood cancers, bone marrow failures, syndromes, and a range of other conditions. However, the overwhelming majority of stem cell transplants that we are involved in are for acute blood cancers. And over the past decade or more, we've seen a steady increase in diagnoses, which has been matched by a real increase in unrelated donor transplants. And you can see there that, in fact, unrelated donors the demand for unrelated donors has increased at a much higher rate than the number of related transplants. And when we look into, well, where do we actually get those unrelated donor stem cells from within Australia? You can see this chart goes back a long way. And you can see way back at the start, when we started as an organisation, it was around 1992. And really the big area of growth back then was cord blood. And so cord blood, which there are 3 cord blood banks in Australia, and we facilitate the searches that are conducted of cord blood units that are held by those banks. So a patient will come to the registry, well, their transplant team will come to the registry, enter their information with us, specifically their HLA and their diagnosis, and then we would facilitate a search that is of the Australian donor base, Australian cord blood banks, as well as all overseas donor registries and overseas cord blood banks as well. So that's part of the system that we have in place to be able to reach out to across the entire community of voluntary donors, including cord blood unit donations. And you can see that over time, there has been a really strong increase in demand for overseas donors and a real steep decline in demand for cord blood units from about its peak in 2007. Now, I'll be talking about the disparity between the overseas donors and the Australian donors in a second, but you can see that in terms of where the demand is lying, the Australian transplant community is very strongly in favour, and this is a strong global trend as well, in actually sourcing cells from adult volunteer donors rather than cord blood units. So we know that patients do better with younger unrelated donors. There is a large and growing body of evidence internationally, as well as within Australia, that the age of the donor really matters to patient outcomes. And particularly in recent years, we've seen the importance of that, the evidence of the importance of age has really been substantiated. And in fact, there is a lot of scientific papers which now pointing out that really donors that are older than 30 do have one of the impacts that that is recorded is that it does impact on patient outcomes. And in fact, for every decade of donor age over the age of 30, that impact can be as much as a 5% reduction in survival outcomes for those recipients. So as this evidence has been coming in within recent years, we have seen a real shift in the types of donors that are selected for Australian and overseas patients. So, of course, we need to, as a donor registry, make sure that we are meeting those shifts in demand by ensuring that we have the right donors to give patients the best outcome. So what we're seeing really in the last 2 years, has been a very significant increase in the utilisation of our 18 to 35-year-old donors, to the point where it is now nearly ubiquitous. It is the exception rather than the norm, that a donor over the age of 35 will be used. And in fact, even younger donors now, as I mentioned, as that research is coming out about the importance of that 18 to 30-year-old age group, we're starting to see a strong uptake in those even younger donors. So some of the questions that prompts for us as a donor registry over the years has been particularly about who are the people that we recruit into the registry. So up until about 5 years ago, we were allowing the recruitment of donors up to the age of 45. We dropped that around 5 years ago to 35 is now the maximum age limit for joining the registry. And we will be continuing to review that to make sure that we are best able to provide donors that meet this particular clinical need for younger donors. And you can see there the average age of our donors has been declining as we have shifted our recruitment strategies to target younger donors. There has been an increase, obviously, therefore, in the proportion of younger donors within our donor pool. We still have a long way to go, and I'll be talking about that in a second. The other criteria as well, this is all in addition to HLA matching. The other criteria that has traditionally been important in the selection of donors has been gender. And there has been a really strong kind of preference towards male donors over female. And that historically, there is, I guess you could say, less compelling evidence for that shift, but there's certainly, if the risk of having a female donor is related to her history of pregnancies and the complications that can arise from an immune system response as a result of that. So there has tended to be, as I mentioned, a real kind of bias towards male donors, and that tends to be about a 60-40 split. What we tend to see is that the younger the donor, the less that gender matters. And that's likely to be directly because younger women tend not to have that history of pregnancy that 40-year-old women would have. So I mentioned before that we still have a way to go in the growing the Australian donor pool. And until we grow the Australian donor pool, we will always lag behind in terms of the use of Australian donors versus an overseas donor. So right now, this year, I think it's around 18% of Australian patient transplants involved an Australian donor. And that's about the same rate that it was when we went into the pandemic. And with the pandemic, planes stopped flying, which meant that all of those cells that were collected from those overseas donors became stranded in airports around the world, unable to get to Australia. And one of the big lessons out of the pandemic for us was that as a registry, there is no other registry in the world that has such a high dependency on donors that live so far away from their patients. So obviously, Australia, very isolated. We are a very long way away from where we source the majority of donors. That 82% of donors for Australian patients are coming from Europe, the UK, and the US predominantly. So what do we need to do to fix that? Well, we need investment. And when we look at the comparable nations to Australia, and by comparable, I mean these are the countries that are transplanting at a rate similar to Australia. You can see there that those countries are investing significantly more in the recruitment of donors. These are specifically looking at the 18 to 35-year-old donors that exist within these countries' donor pools. and Australia right at the end there. That really is, it tells the story. So this is something that we've been pushing governments for several years now. We had hoped that the pandemic, being an excellent example of why it is not a great idea to be so dependent on the rest of the world for such a critical resource. We thought that that might have shifted the dial, but we can see that there is still further work to go. And in fact, one of the things was noting before with the cord blood banking and the very low rates of cord blood utilisation within Australia and around the world. And yet each year more is spent in cord blood banking than has ever been spent in promoting stem cell donor recruitment, joining the registry, the need for stem cell donors. So we've still got a long way to go in order to really lift that level of awareness within the community so that we can start to see more young donors joining the registry, and so we can reduce that reliance on overseas donors. So what is the experience of being a donor? So I'm going to run through the joining of the registry, and then I'll hand over to Hung, who's going to be talking through the rest of the donation journey. I guess I'll be starting off by saying that while I'm focused on the joining of the registry, and we'll go through that, it's important to bear in mind that most people who join the registry will never be asked to donate. In fact, will never be even shortlisted to donate. And Hung will go through the reasons for that. But nevertheless, we call everybody that signs up a donor. And that is because they are offering hope to patients not only within Australia and around the world. And we all know that matching HLA is a numbers game. So the more people we have on the registry, the better the chances of finding a matching donor for every Australian patient. So, but nevertheless, the reality is your chances of winning the lottery are probably about the same as being asked to actually donate if you want to join the registry. So the headline of how to join the registry is pretty straightforward. Head to our website, stemcelldonors.org.au, and there's a screenshot there of the page that you will land on. You will then be asked how you wish to join the registry, and you've got a couple of options. And the reason why there are options there is because we need a sample of your cells upon registering with us so that we can get those tested. And that's the means by which we can then match you to a patient. So what are we testing for? HLA tissue type, as you would expect, blood group as well, and your exposure to cytomegalovirus, right, which is a very common infection in the community, but as you're probably aware, can have a very big impact on transplants. So those are the three things that we test our donors for the moment that they join. Obviously, if they are asked to donate, they are tested for more things, but this is the upfront testing that is done. And you have two ways that you can give us your cells. One is by home delivered cheek swabs, which, as it says, they're just really easy to do, and it's all done through the post. Or when you next donate blood, you can elect to have that option there, and Lifeblood will then facilitate your taking of an additional sample to allow you to join the registry. You may have seen around the place, increase, whether it's on social media or even on billboards, we're starting to see more and more patient campaigns being run, which is situations where a patient is in that searching phase, looking for a donor, or in another very early stage where an unrelated stem cell donor is being considered for them. And they really want to do something, or their family really wants to do something. And so they're approaching us to try and leverage their own networks, to spread the word amongst their own community, and to see how they can help us recruit the kinds of donors that I can tell you will never be used for that patient. I don't think in the history of stem cell donor recruitment around the world, I think there might have only been 1 or 2 instances where that patient campaign actually resulted in the recruitment of the donor that went on to donate to that patient. So we make that very clear to everybody. This isn't about you finding your donor, but this is about families who really want to do something and who can see this as being a really effective thing that they can do to help, if not their own family member, but then somebody else's family member. So we've got a number of campaigns that are running at the moment, and we've just given the example there of Nim, and who has done a lot of promotion and has recruited hundreds of donors for us, and so we're very appreciative of these campaigns. Of course, joining the registry is one thing, but as I mentioned, the vast majority of people won't go on to donate. Those that do, they may not get that call. They might get a call weeks after they've joined. It could be months, it could be years after they've actually joined the registry. So we've got a big challenge there to keep these donors engaged and willing to say yes when they do, if they do, get that phone call. Now, historically, this has been another area where the Australian donor pool was underinvested in. And in fact, when I joined, we didn't speak to our donors at all, ever, and after they joined. And that was it. That was the end of the conversation. And so Australian donors had a little bit of a reputation as being kind of either not reliable or not available. They just generally, you know, if you gave them a call, we were never able to get them. Well, not never, but you know, it was a lot harder to get them to say yes. And in a way, the pandemic has been a real boon for us in this regard, because we've put a lot of effort into engaging our donors, figuring that if we've got a very small donor pool, we have to make sure that we are keeping those donors engaged and much more likely to say yes. And so we keep a track of how our donors go relative to overseas donors that are requested for Australian patients. And for the first time this year, we now see that Australian donors, in fact, are world leaders in being reliable and available. So 69% of the time when a donor is requested to take that next step for a patient, they will be saying yes. We are absolutely available. So that is hugely impressive results. And the German donors were always the gold standard. And so now I'm very pleased to say that, that we have overtaken Germany as a population. So we do have a highly engaged donor pool. It's just too small. We need to grow it. Now at this point, I'm going to hand over to Hung, who is going to take us through the next part of the process.
Right, thanks, Lisa. So what I'm going to be talking about is the rest of the donor journey, if the donor ever gets there, of course, and also there's some, I guess, frequently asked questions at the end there that donors, I guess we find that donors ask, as you know, through this journey. So yeah, if we could go to the next slide, please, Lisa. So if you are called up for a patient, or a patient has been matched to you in a transplant centre somewhere in the world, the first thing you'll know about it is that you'll get the registry, us, will get a request for you to be verification typed or have confirmatory typing. This is basically just a mandatory technical step in the process to make sure that you've got the right person and the person has the right HLA type to match the actual patient. And that's done by sending a sample from the donor registry from us to the transplant centre's own lab to verify their HLA type. Now, because of course we have to contact the donor and get a blood sample off them, we do take the opportunity to also test the donor for some very basic mandatory infectious diseases, and also ask about their medical and travel history to assess their general fitness for donation, and also to identify any potential risks that there may be to the recipient. So what happens when in this step is really that a transplant centre, from their patient's point of view, will try to look around the world for matches, HLA matches. If they're available, it's best that they try to request multiple donors in a short list. Now, there may not be, of course, any donors, match donors, or there may only be one or two. But if possible, you probably want to be shortlisting, 4 or 5 or even 6 donors, because obviously some of those donors may not be suitable or available, or have some issues. And if you then, of course, lucky enough that your patient has multiple donors, you'll choose the best donor for what we call workup examination, to actually proceed, hopefully, to a collection or a donation. And the second choice donor will be then asked to be a backup donor. And that's, I guess, the ideal safety situation for the patient in case the selected first choice donor doesn't work out somehow. Now, traditionally, we have found in the Australian registry that only about 1 in 1,000 of our donors historically have actually gone on to actually donate. So that's, I guess, gives you an idea. I was until I turned 60 and faced mandatory retirement. I was on the registry for about 30 years, and I never got a single call. And of course, this was the days when, the registry didn't really talk to donors, so I didn't hear anything. So that's the first step, I guess. If you are as a donor, if you've joined the registry and you get the call, this is the first step. Next slide, please. Now, if you are the chosen first choice donor, you will then be asked to proceed to a workup assessment, which basically is the full ultimate assessment that takes place before you'll be donating. It involves basically the same questionnaire on medical and travel history that you had at the previous stage, and some infectious disease testing is the same. But in addition, there will be extra testing for infections that the transplant centre is concerned about, and also for infections that you may be at risk because you've reported a history of travelling to a country with malaria risk or dengue risk or something like that. There's also testing for the donor's own benefit to make sure that they are a fit person. So these are basically your basic blood tests that you might have if you see your GP for a checkup, full blood count, electrolytes, and liver function tests. There's testing to make sure you don't have an inherited blood or clotting disease, because those are things that you would transmit to the recipient if they affect your blood cells. And also, if you are a female donor of childbearing potential, there is a pregnancy test, because we don't allow pregnant women to donate for their own safety. And there's, of course, a consent process, which is done at the collection centre, which for Australian donors is always a public hospital, a large public hospital, generally the large public hospital that also does transplants themselves, but not necessarily. So next slide, please. Great. So what then happens if you get through the workup process, you're fit, and there's no issues that the transplant centre is concerned about in your workup sort of assessment. There's two methods of donating your stem cells or collecting your stem cells as a voluntary donor. Now, the old school traditional technique is a bone marrow harvest, which is where bone marrow is extracted from the iliac crest of the pelvic girdle. This is done under general anaesthetic, and it requires pre-anaesthetic assessment, of course. It's painless because you are asleep. And it's generally done as a day procedure, although there are some hospitals that do still routinely admit their bone marrow donors overnight. But this method, it's the traditional and oldest method. It's still the best option for some categories of transplant patients, particularly children, and also children and adults with severe aplastic anemia. But it's really only going to be about 1 in 10 donors these days who is asked to donate by this method. 9 out of 10 donors are asked to donate in a much, I guess, more straightforward and simpler way, which doesn't require an anaesthetic or an operating theatre. And that, of course, is your peripheral blood stem cell collection. This is using a cell separator machine, which we call an apheresis machine, much like is used for some types of blood donations. But the catch here is that the marrow stem cells are not normally found in the bloodstream. They're normally found only in the bone marrow. So to push those cells into the bloodstream where they can be collected by the apheresis machine, you need to have injections of what we call a cell mobiliser or stem cell mobiliser. In Australia, the standard product is GCSF, which is a natural artificial version of a natural hormone that stimulates a white cell response. It pushes white cells from the bone marrow into the bloodstream, and along with those white cells goes your stem cells, which of course are making those white cells. So it's basically generally a 4-day course of GCSF, and the apheresis collection itself is just pretty much like a very long blood donation. It takes between 4 and 6 hours for the donor. But of course, there's no anaesthetics required. It's simply just sitting there on the machine for quite a while with a book or an iPad or something like that. Next slide, please. So after the donation, we have a standard follow-up protocol for our donors. So basically, we first follow them up at 72 hours or 3 days after their donation, and then we continue that follow-up weekly until they are fully recovered. Generally, we find that at 1 week they are fully recovered, but sometimes we do have to go to that 2nd week. At 3 months, we do some routine blood tests, mainly full blood count and liver functions and so forth, and we ask them to have that done by their own GP with a checklist. And then it's a mandatory requirement of the World Marrow Donor Association that we will follow up, maintain that follow-up annually for 10 years to check for long-term adverse effects of the donation process. Next slide, please. Okay, I think from this point on, we've got some frequently asked questions.
We do.
Now, these, of course, are not frequently asked questions from people on the podcast or the webinar, these are questions that are generally asked by our donors. So it's very much from our point of view. But one thing that we're quite often asked, of course, is what is HLA and why is it important? I guess this audience probably has a pretty good idea that HLA stands for human leukocyte antigen. It is this system of markers on the surface of white blood cells and many other cells, but white blood cells have the most complete set, or the full set, of HLA, and it's incredibly diverse. And of course, that's why it's so difficult to match a patient with a donor. So in a general sense, of course, we know that successful allogeneic or transplant from a donor to a recipient relies on matching HLA markers between the recipient and their donor. So we also, of course, test red cell blood groups at enrolment when you join the registry. And so they are important, of course, but it's I guess probably something that you guys probably have an idea already, that it is very common to change your red cell blood group when you have a transplant. And that's because, of course, the red cell blood groups are inherited completely separately from the HLA types. And around about half of transplants involve a change of ABO and or RHD, positive or negative blood type. So it is obviously not a deal breaker, but a change of ABO type in particular means that there is going to be some incompatibility between the red cells of the recipient and the red cells of the donor. And that causes certain complications, of course. The reason that ABO incompatibility is I guess, inevitable if it's different is that for ABO, the antibodies to A, anti-A, and to B, which is anti-B, they occur naturally, whereas other blood types, blood groups, there's no, the antibodies do not occur unless you're actually exposed to someone else's blood. And so it causes, as you can imagine, all sorts of complications in terms of not only the infusion of the transplant itself, reaction obviously can occur at that time, but also in the support of the patient around or before, during and after their transplant, with blood transfusions and so forth, that there's obviously needs to be a protocol, which there is for each combination or change of ABO direction to accommodate those potential incompatibilities. Next slide. Okay, so another question, of course, is that CMV is the third thing that we test routinely at enrolment. What is CMV and why is it important? Cytomegalovirus is basically medical Greek for big cell virus. If you look at the white cells that infected by CMV, they're typically they swell up and they get very large. So CMV is an infection of white blood cells, and like all other members of the herpes virus family, including Epstein-Barr virus, which causes glandular fever, and varicella zoster virus, which causes chickenpox and shingles, it is an infection that is very common in the community. But when you get it, and even when you get over it, you never permanently get rid of it. It becomes latent or permanently latent in your white blood cells for forever. Now that's fine if you've got a normal immune system. So that's why, a lot of people will have antibodies or markers of latent infection for EBV, varicella zoster virus, and CMV, and they will never run into any problems unless they have their immune system suppressed. So CMV is generally in a healthy person completely asymptomatic. I think 80% of people have no symptoms whatsoever. And even if you do get symptoms, it's pretty mild. It's like a glandular fever light sort of illness. But in people with a suppressed immune system, CMV can cause life-threatening infection, serious disorders of the immune system. And that's why it's generally, I guess, a good idea, but not a deal breaker if you can't do it, to try and match donors and recipients with their CMV antibody status. So to avoid the two possibilities, which is one, that a donor who has CMV can transmit CMV to a recipient who doesn't have CMV. The other possibility, of course, is that a donor who doesn't have CMV may not transmit, will not transmit any sort of immune control from their transplant or their donation to a recipient who does have latent infection. But of course, there are such things, of course, as antiviral medications that can be used for CMV. So this sort of mismatch is not a deal breaker if you can't, if it's unavoidable. Next slide, thank you. So what is GCSF? That is the mobilizing agent that we use for 90% of our donors. GCSF stands for granulocyte colony stimulating factor, which is, as I mentioned before, a man-made version of a hormone that stimulates white cells. White cells and, of course, every other blood cell are made by the blood-making stem cells in the bone marrow, which we call hemopoietic or hematopoietic stem cells. And GCSF basically just causes an exponential chain reaction where these stem cells are made to multiply themselves and ramp up the production of white cells. So that produces such a big excess of white cells and stem cells themselves that they then spill over into the peripheral bloodstream where they can be collected. The common side effects from GCSF relate to basically the very high white cell numbers in the bloodstream. So white cells, of course, they kill infections and other nasties in various ways, but many of those ways relate to some poisons like cytokines that they release, and those cytokines cause flu-like symptoms like aches and pains, headache, fatigue, etc., fever perhaps. Now, in a healthy person getting artificial GCSF, there's generally these flu-like symptoms are not terribly unpleasant. They're not sort of the degree that you actually might have a flu or something like that. Now, another concern about GCSF traditionally was that there was, if you'd stimulate the production of white cells by hemopoietic stem cells, that maybe you could increase the recipient's, the donor's risk of blood cancer in the future. The good news there is that we've been doing this for quite some years now. There's absolutely no increase observed in reported cancers after peripheral blood stem cell donations. And also in the laboratory, we'd also have done studies that show that there's no increase in actual mutations that we can detect in a healthy donor who's given GCSF. So that's both very reassuring sort of findings. Another very common question, I guess, after the cancer question, which or even more common than the cancer question is, if I donate my stem cells, am I going to be short of them forever, or is that going to decrease my immunity? So the short answer to that question is no, that there's no effect on your own immunity. And the reason for this is different for bone marrow harvest versus peripheral blood stem cell collection. Now, with bone marrow harvest, it's because the process is extremely inefficient in collecting the stem cells, because they actually live in the most sort of convoluted nooks and crannies of the marrow cavity. So if you stick a relatively large needle into that cavity, you're sort of sticking it into the middle of the cavity. And therefore, the dose that you collect is actually very small and represents only a very tiny percentage of the donor's total hematopoietic stem cell population, which of course is present in the marrow of all the, in adulthood, all the sort of central bones around the spine and sternum and hips and so forth. Now, the reason that there's no effect on immunity for peripheral blood stem cell collection, even though the dosage of stem cells collected is much higher, is that the GCSF expands the stem cell population massively and creates a large and temporary excess of stem cells as well as white cells that we can collect. So there's no net loss, in fact, a net gain of stem cells in that scenario. So again, no concerns about being short of stem cells in the future or having your immunity somehow affected by the donation process. And that's the end of the FAQs. Hopefully we've left some time for some more of your own questions.
Thanks, Hong, and thanks, Lisa. That was incredibly informative, even for someone who's worked in transplants for 35 years. And look, I concur with you. I joined the registry in 1989 and have never been, I think I'm number 257 on the registry, something wild like that. So yeah, and I've never been called up. There are so many questions. I actually don't think I've ever seen this many questions on one of our webinars. I'm going to mix them up a little bit. And I'm going to start with a question from Mark. Why the name change from ABMDR, or Australian Bone Marrow Donor Registry, to Stem Cell Donors Australia? Lisa, I'll give that one to you.
Yeah, and it's to do with the bone marrow. Bone marrow, in the minds of most of the general community out there, the idea of donating bone marrow, they think of giant needles going into their hip bones. If you've ever watched any of the big US medical dramas, they always represent it terribly. The donors are always awake and writhing or screaming, or anyway. Lots of bad thoughts come to mind when people in our target audience for recruitment hear the term bone marrow donation. A stem cell donation, however, which is the umbrella term, given, as Hong said, 90% of donations now are not bone marrow, but they are the stem cells. So stem cell has much less of a negative connotation for people, and it does more accurately reflect what we're actually all about. So hence why, yeah, the name change.
Thanks, Lisa. A question from Rochelle. Given that many of our donors are sourced internationally, what's the cost for sourcing international donor stem cells?
It varies. You'll be very unsurprised to learn that if the donor comes from the US, it is considerably more expensive than anywhere else, just about. But we kind of average it out to about $50,000. Really is kind of the all-up cost, and that cost is borne by the Commonwealth government, and so they directly fund the import of cells into this country. So. Yeah, last year when you think that we're doing a couple of hundred of these, more than actually, every year, about 250, those numbers add up.
Thanks, Lisa. Hong, I'll throw this next question to you. And there are a couple of questions that that actually have similar theme. One person's asked what's the difference between a 10 out of 10 and a 12 out of 12 matched donor, and follow on, what's the chance of finding a fully matched donor?
Okay, so So basically, the difference between a 10 out of 10 and 12 out of 12 is basically just that 10 out of 10 is really just looking at the first 10, I guess, that we discovered in the HLA system. And as time went on, I guess, I mean, the standard in the early days, of course, was, sort of 4 out of 4 because, we only had two alleles, so knew about them. So 10 out of 10 became, I guess, over time, the standard. But of course, as time went further on, of course, we discovered more HLA alleles and therefore, I guess you could go to 16 out of 16 these days if you wanted to, but it doesn't seem to make much difference beyond 10 out of 10. What was the second question again? The
chances of finding a
chances.
fully matched donor.
I think Lisa might have better stats than me, but I think that in general terms, if you're a person of European ancestry, your chances are way above 90% of finding a 10 out of 10 match, which is really all you need. If you're not of European ancestry, your odds go down quite a lot. And I guess the worst chances reflect probably the representation of ancestries on the worldwide registry. So basically, the lowest chances are if you have African ancestry, because there are less, they're the least represented on the worldwide registry.
Yeah, look, that's right. And there's been a lot of attention on this over the last couple of years as well, trying to find ways over this HLA hurdle. As Hung said, you could go to 12 out of 12, 16 out of 16, but of course, every time you get more and more granular, you are looking for more and more HLA matches for that one individual. The chances of actually finding somebody decrease significantly. And so particularly in the US, but also within Europe, it's been a lot of research being led within the US to try and look at ways of having successful transplants with mismatched donors. And there has been a lot of success in that area through the use basically of, if you like, preemptive therapies, chemotherapies, to anticipate the graft versus host disease reaction. And so now they're having some really good success. And in fact, that's where the age data has all come from, because what they're finding is that, in fact, you can get away with mismatches on HLA, quite significant mismatches. They're looking, they tend to measure out at 8 in the US. They don't really buy into these additional, I say, as being important. But, they're looking at 6 out of 8, 5 out of 8. They're doing much lower matching. But what they're finding is, if provided the donor is young and the right sort of therapy, the treatment course is adjusted, then the outcomes are, comparable to having a fully matched donor. And that is really positive news for people who would ordinarily struggle to find that match. As Hung said, if you are not from a Northwest European kind of ancestry, your chances pretty much are halved. And then depending on where you are from the world, they can get quite low indeed. So this is good news, that you can get away with having a less precise HLA match, but with, provided the donor is of the right age, you have a comparable outcome.
Thanks, Lisa. That's fantastic, and actually segues beautifully into a really important question around populations that are less well represented on the registry. The question is around the likelihood of Indigenous recipients, patients, finding a donor and receiving donor cells. So, how well represented on the registry are our Indigenous peoples, and what steps are being taken to increase recruitment?
Yes, absolutely. The First Nations Australians can't go anywhere else really to find a matching donor. They are relying on the Australian donor pool. And while our, when you look at percentages, so we do have a higher percentage of First Nations donors on our registry than you would find in the general population. So I think it's sitting nearly at 5% now of our donors do have Indigenous ancestry. It's around 4, I think. Nevertheless, 4% of a small number is a very small number. And so, we really would like to see, as well as growth in the overall donor pool, we do need to grow that proportion. So we've done and we are currently engaged in several initiatives. We're working with partners across the First Nations space to look at what are the best ways that we can engage with this community. Particularly, we are looking for donors that are obviously young, but also ideally that are urban based, because the reality is that they do need to make their donation at a large hospital in a capital city. That's the arrangements in place within Australia. And so and they need to be accessible and available. And that does mean that remote communities, it is particularly difficult. Even if we recruited them, it would be difficult for them to then come in and make that donation. So our focus has been primarily at this point around promoting the need for stem cell donation amongst First Nations communities, and to develop the kind of culturally safe educational materials that those donors will need.
Thanks, Lisa. There's some really great questions on the theme of advocacy and equity. There's a question here from Rochelle, I think, who asks, yes, from Rochelle, who asks, where are the donor swabs processed? Is this conducted in Australia? And if not, why?
So there are 2 laboratories around the world that are dedicated specifically to the testing of cheek swabs for the purpose of joining a stem cell donor registry. And that is because it is a weird test to run off a cheek swab if you were a patient, for instance, or really in any other kind of context. So we have, as a collective of donor registries around the world, a very unique set of requirements to conduct this particular type of testing in this particular way. And the reason why it developed was because it was recognized that requiring people to give a blood sample was not only onerous, but that it really limited the number of people that were prepared to join. And the cheek swab results that have been honed in these 2 labs. So one is located in the US and one is in Germany. We have used both over the recent years that we've been doing the cheek swabbing. Ultimately, I am agnostic as to where the cheek swabs are done, as long as they are done reliably, quickly, and cheaply. You have to think that these labs, between them, are processing around 6 million swabs, so donors, enrollees. So everybody has 3 swabs in Australia. Some countries make, if you're joining, you do 4 swabs. But if they're handling, 6 million people's swabs coming in between the 2 of them, these guys are just robot heaven when you go in there. So they're quick and they're effective and they're reliable. So there are no labs within Australia that offer this service to conduct the testing for those 3 things. And maybe there one day will be, which would be great. But until then, these we hold contracts with labs in Germany, which is run by another registry, so it's all very kind of in-house, or a US lab.
Thanks, Lisa. We're right on 8 o'clock and we do try and finish on time, but I am going to draw the audience's attention to some answers that Thank You Hong has put in the chat. One was in relation to a question from Louise around her sister donors follow-up, and Hung has just clarified that we are talking about unrelated donors in this presentation. He's also given some advice around registered donors from overseas transferring to Stem Cell Donors Australia if they have Medicare cover. Before I hand back over to Angela, really quickly, I'm just going to ask Lisa to very briefly answer a question, or Hung, whoever wants to take this, about there was a question around what can we do to support recruitment of donors.
Okay, so two key things. Spread the word. That is really the critical thing that right now. Spread the word amongst everybody you know that is 18 to 35 or has somebody in their life who is 18 to 35, and let them know about the donation process, and kind of demystify it, and encourage, but also explaining the importance of it. I mean, obviously it's a profound gift that these donors are making, and it is life-changing for the recipients. So it is a really profound experience. So spreading the word is the best thing that can be done. We also desperately need to have sustainable funding for this. And really that's a political kind of question. So we encourage people, if you are that way inclined, to write to your local MP. Where the funding is state and Commonwealth, so you can go to town with whoever you like, take your pick of targets. They're all responsible for funding or lack thereof into donor recruitment. So that'll be the two top tips.
Thanks, Lisa. That's fantastic. Sam, that's an excellent question that you've put in the chat. And can I ask you to direct that to your transplant team or your long-term follow-up team from your treating centre, please? And I'm sure they'd be really happy to answer that question. You could also get onto the Arrow website and have a look at the Straight and Marrow podcast episodes. There's some really great episodes on survivorship, graft versus host disease, long-term follow-up. So I urge you to check those things out. Thanks very much, Lisa and Hung. That was absolutely sensational. I feel like we almost need to get you back again in the not too distant future. I'm going to hand back over to Ange, and thanks everyone for attending.
Thank you.
Thank you, Yvonne. And yeah, I absolutely concur. Thank you so much, Lisa and Hung. That was really, really brilliant. And yeah, I've definitely learned a huge amount tonight, and I'm sure our audience has also. I just want to also say that stem cell and bone marrow donation is something that I am eternally grateful for. After my daughter received a life-saving transplant from an anonymous donor some 8 years ago. So for all of you out there, if anybody is thinking of jumping on the register and obviously are in the right age demographic, please do, because you may well be the answer to someone's prayers, and it absolutely is life-changing for both parties. So thank you. To our audience, thank you for coming along. We truly do value your support. The recording of this webinar will be available within the coming days, and so you will receive a link to the recording, and that way you can watch it back. We would also like to ask you to please stick around at the end of this webinar. We do have a very short survey that we do love to get your feedback from. It's completely anonymous, but we value the feedback. We do take everything into account, and it does help us improve our service within Arrow. So please do stick around and do that. If you do have any questions at all regarding tonight's webinar or any of Arrow's services, please jump on our website. It's www.arrow.org.au, and you can also email us at info@arrow.org.au. We are here to support all our BMT, stem cell and CAR T therapy patients and their carers. So please reach out to us, or do reach out to your treating healthcare teams, and they can point you in the right direction. So watch out for any future webinars, and until next time, take care.